Hello and welcome to Doc Talk with Monument Health. I'm Mark Houston. We're replaying this episode today because May is Skin Cancer Awareness Month, and it fits. Dr. Christopher Gasbarre is a dermatologist with Monument Health and Spearfish, and he covers a lot of ground here: sun protection, risk factors, sunscreen myths, and what to actually watch for on your skin heading into summer. Enjoy episode 92 with Dr. Christopher Gasbarre. Hello again, everyone, and welcome to this edition of Doc Talk with Monument Health. I am Mark Houston, and joining me today is Dr. Christopher Gasbarre, dermatologist from Monument Health and Spearfish. Doctor, welcome to the show. Glad you could make it over.
Yeah, thanks for having me.
Absolutely. We're I know this podcast specifically is going to run in the month of May, which is Skin Cancer Awareness Month, correct?
Yep.
All right.
Absolutely.
So that's what we're going to get into here in just a sec, Doctor. But first, let's find out a little bit about you.
Sure.
You're not local, I found out.
Not originally.
You're kind
no.
of. I mean, you've been here 12 years, right?
That's right. Yeah, going on 13 now.
Okay.
But yeah, originally grew up in Maryland, did my training, most of my medical training in Ohio, and was on staff there at Cleveland Clinic for a while before I came out here. Have bounced around, medicine, how medicine goes. Training is long and varied, so you bounce around quite a bit throughout college and med school. But settled out here. Had a good friend from medical school who had moved out here to practice, and made an offhanded comment to him that he was looking at the area, and I knew the area because my parents had retired out here, and said if they're ever looking for a dermatologist, let me know. And so it worked out.
That's perfect. Yeah. What is it? Is it a drastic change from working at a place like a hospital in Cleveland to a hospital in Spearfish, or is it similar?
A lot of things are similar, and then there are big differences. Your patient population changes based on where you live. For things like dermatology, demographics make a huge difference on skin type and risks. Also, skin diseases look different in folks with different skin types, different races. You will see there will be differences. So, but otherwise, people are people. And so the practice of medicine is largely the same. At different institutions, the practice of medicine can look very different. I was at an academic center, which was a big hospital, where over time you end up subspecializing and getting very narrow focused in what you treat. I was exclusively a skin cancer surgeon for the most part in my time in Cleveland when I was on staff there. Now I do a little bit of everything, general dermatology, but also still have a dedicated skin cancer surgical program as well. So a little bit of everything, but my passion, skin cancer, and the treatments of skin cancer, one of which is Mohs micrographic surgery.
And that I know we're going to talk with you in a later podcast as well, which
Correct.
I think I don't know how many people are super familiar with it, but it is a really interesting, newer technology, isn't it? Isn't it something that's a little newer? How long has Mohs been around?
Interestingly enough, Mohs micrographic surgery was developed by a guy named Frederick Mohs, actually in the late 1940s and early 1950s, believe it or not.
Wow.
But there have been some advancements over time. The biggest leap in advancements, and not to get too far into the weeds, but biggest advancements were some change in technique and procedures in the late 1970s, early 1980s. There have been advancements steadily since then. So we are doing things now with Mohs surgery that weren't done then. But the idea actually originated late 40s, early 50s.
Wow.
Were the first papers. But it didn't hit mainstream. Fred Mohs was actually a general surgeon by training. Nobody really bought into what he was doing, and a couple of dermatologists got a hold of him, and it changed the field. And now it's a fellowship in dermatology, and there's a board exam for Mohs micrographic surgery.
That's got to make him feel pretty good. You guys laughed at me, and now look at you. All right. Yeah. Well, we will. We're going to have that one in another episode coming up. But let's just kind of focus this a little bit, Doctor, on just skin cancer in general, right? Because as we get our brief 3-month span out here of sunshine, people run outside in as little clothes as possible to just be out in it, right? Some sun, obviously, we know is good for you. The vitamin D that you get from it. I'm sure there's other benefits of being out in sun in general, isn't there?
There can be, and in moderation. So the thing to think about with sun exposure and ultraviolet light exposure is what we're really talking about is the UV spectrum in sunlight can be damaging, and we know it's a carcinogen, so it causes cancer. Mm-hmm. The thing to keep in mind with sun is in moderation, and if you protect your skin from the damage, you can enjoy your time outdoors. You don't need to live in a cave.
Right.
However, there are a lot of misconceptions about the sun as well as about UV exposure. I get a lot of questions about vitamin D. There is a way to convert vitamin D in the skin with sun exposure so that your body can produce more vitamin D from precursor molecules in the skin. But there are other mechanisms of doing that as well. And also you can do it more safely through supplementation if you have a low vitamin D level. So you don't have to necessarily expose yourself to ultraviolet light to get vitamin D. That being said, the amount of sun you need to convert that vitamin D, if you're going that route, is really only about 10 to 15 minutes.
That's it.
Of midday sun. So
you want to be out in it so much longer.
We all like to think, oh yeah, that gives us free reign to go
Right.
go spend all day outdoors, which we can do. Just do it responsibly.
Yeah.
So the cool thing is that sunscreens and sun protective clothing have come a long way, even in the time that I've been practicing. It used to be that sun protective clothing felt a lot like wearing a plastic bag.
Yeah.
And the sunscreens weren't very elegant, and they've really come a long way over the years. So now it's pretty easy to find something that is workable for most folks, either in sun protective clothing or chemical sunscreen agents.
Okay. Well, beyond the sun exposure, are there any other like hidden risk factors for skin cancer that most people wouldn't be aware of?
There's always, for different types of skin cancers, this can vary. Genetics play a role in melanoma risk in particular. So when you look at, not to get too far into the weeds, but when you look at skin cancers, there are two broad classes. There are melanomas and non-melanoma skin cancers. Melanoma is the one that we worry most about. It gets a lot of press because it can metastasize or spread to other organs. And when we look at cancer in general, the main risk to our lives from cancer is metastasis or spread. So because melanoma has the highest metastasis rate of any of the skin cancers, it gets a lot of attention. There's probably about, I think the numbers currently are somewhere between 75 and 100,000 cases in the U.S. On the flip side of that, there are probably 4 million plus cases of non-melanoma skin cancers in the U.S. a year. So those are generally basal cell and squamous cell carcinomas. Those are way more common. I see those every day in my office. And those don't have as much of a genetic link, though they are linked to skin type. So if you're fair complected, blue eyes, red hair, that can be a risk factor.
Blue eyes? Really?
Unfortunately, yes. But that also falls in with melanoma as well. Now, with melanoma, there are actually family genetics that can come into play. So if your first-order relatives, we call it in medicine, which is your parent, your sibling, or your children have had a history of melanoma, your risk is actually higher. And so we usually recommend getting skin screenings for those folks. So melanoma has some other independent risk factors. The other things that are kind of unique with melanoma as far as risk factors are a history of blistering sunburns as a kid. So the more blistering sunburns you had as a kid, and also tanning bed exposure seems to be a independent risk factor for melanomas and non-melanomas for that matter. What that seems to mean to me is that melanomas are very sensitive to high-intensity ultraviolet light exposure, especially at a young age. And so we really stress protecting kids from that ultraviolet light exposure.
Well, now you mentioned tanning beds a little bit, indoor tanning, UV tanning beds, things like this. There's got to be, are there misconceptions about safe tanning practices that kind of, I don't know, maybe irritate you?
Yeah, so I guess probably the most common misconception I've heard over the years is that you want to get a base tan before you go on a trip because it will protect you from that risk. That's not true. Think of a tan as your body's natural defense mechanism to ultraviolet exposure. Your body's saying, I just saw too much carcinogen and I'm going to try to defend myself as best I can by increasing pigment production, which will help protect the skin from ultraviolet light. So it's a defense mechanism. By the time you tan, you've already been exposed to that light or to that ultraviolet light. So it's better to not quote get color. However, it does happen, and like I said, I try to tell patients you have to live your life. You have to do reasonable things to
Yeah.
protect your skin. You can't expect to always get it right. You're going to make mistakes, and that's okay, but do your best to make sun protection part of your day-to-day regimen so that consistently over time, you're more often right than wrong.
That's interesting. I wonder how many people have ever thought of a tan as being a self-defense mechanism. I mean, that wouldn't even have occurred to me until you mentioned that. But of course, that makes perfect sense.
That's the way I like to think of it and try to explain it to folks. But it's not meant to be. Interestingly enough, over history, the history of tans in the United States is kind of interesting. They haven't always been fashionable. There was a time in the United States where the exact opposite was fashionable, and it was largely because tans were considered an element of the working class. If you were working outside,
of course,
you had a tan, and if you were affluent, you were not. And so there was a big switch in probably the early 1900s with that, because European started and affluent Americans started vacationing in sunny areas, and so all of a sudden that switched. But for a long time, it was the exact opposite. I'm affluent, or I'm not affluent, and I'm very, very white. So I don't know what that says. But that's fine, I guess. It means you're doing the right thing. With your
there
sun
we
protection.
go. Exactly. Now, a lot of people, I do recommend, and I think you would recommend too. Is there a specific age you would recommend people coming to see a dermatologist, or should it be a yearly thing like any sort of checkup?
I think it depends on risk. So if you have a strong family history of melanoma, if you have a strong family history of abnormal moles, getting a baseline check in childhood, especially if you have some moles, that's always a good thing. And then we can base follow-up from there.
Yeah.
For folks that have a history of skin cancer, I see a lot of those folks at least every year. I have some folks I see every 3 or 4 months because they develop precancers and cancerous growths on a quite regular basis. And so there are some things we can do to mitigate that a bit as well. But surveillance is still our best defense. So getting an early eye on these things, because treating them when they're small and less aggressive is always a better way of handling these. Yeah.
A lot of us too. I think we self-examine, examine as well, standing at home, looking to see if things change. Because having gone to dermatologists, that is one of the things they will mention is that you will probably tell, if you see anything that starts to look different, if it starts to change, get bigger, whatever, then that's maybe you should come back, right? Are there anything like technological advances on the horizon for self-exams that might help us better detect when we don't come in to see you? Like if we have a yearly exam, but 6 months in, we're like, well, wait a minute, I'm not sure. Don't know if I need to go. Are there anything that's coming that help better self-examinate?
So great question. Yes, there are some things in the pipeline, but one of the things, I'm old enough now where digital cameras have revolutionized the way I take care of patients.
Sure.
When I was in my training this is going to date me. Early in my training program, we were still using paper charts for our medical records, and we were taking Polaroids and film photography and Kodachromes of patients and skin lesions. Now with phones, my patients can document spots as they evolve and change. And so I'll have folks come in and I'll ask them to take pictures of things that they're concerned about. They can also upload them into their own medical record now, and I can review them remotely. So telehealth and telemedicine has changed how we can interact with our patients dramatically in dermatology. Dermatology is one of those fields that's naturally suited for telehealth, and so it's really been helpful to have that technology available. And it's relatively, what we think of now as relatively simple technology, but it really has changed the way we can deliver patient care.
Boy, that has to be. That's had to have saved many lives, just the technology of being able to do that and get it to you guys.
Yep. Yeah, absolutely. And to your earlier question, there are things in the pipeline where we are going to be able, I think, to do more with less invasive techniques. So currently, if you come in and I'm concerned about a lesion, ultimately we're going to have to take a piece of that and send it for a biopsy. I think going forward, and there's work in this area, but nothing quite ready as yet, there will probably be methods where we can do genetic analysis, for example, on a swab of a lesion, or use essentially a algorithm tied in with digital imaging, or even something called confocal microscopy, where you can actually put the microscope on the skin to get a look at a lesion without removing it.
That's amazing.
So those things are all in the works in various stages. So I think I like to tell people this all the time. People say, well, you're a Mohs surgeon. And I say, do you really want surgery to go away? And I say, well, I'm actually a skin cancer doctor, and really I'm going to use any method. I love doing surgery, but if that goes away tomorrow and we have a way to treat skin cancer with a 98% cure rate without doing surgery, well, that's what we're going to do.
Right.
And so I'm hopeful that I see something like that in my career. I don't know if we will, but that's kind of my hope. So I think there's a lot going on in terms of the genetics of cancer, and looking at how cancer cells respond based on their gene expression. And so there will be a lot of there's a lot of therapeutics looking at that that we currently use, but also in development. So I think in diagnosis there are going to be some advancements, and there are also going to be a lot of advancements in treatment.
That's going to be it. It is amazing. I mean, that field, almost all any of the medical fields change so quickly. I mean, the technology that comes out, it has to make your job exciting too,
It is.
To learn this new stuff.
It is. You're constantly learning. It's like most things, right? I think almost any profession, you're probably constantly learning.
You want to anyway.
And want to be.
Right.
It's a absolute requirement in medicine that we constantly learn. The things that I took as verbatim when I finished my residency, some of those things are no longer true, and that's a great thing. You look back and say, in the history of medicine, you can look back 100 years and say, "Wow, how barbaric!" Well, they're going to say the exact same thing about some of the things we're doing now. So, so I'm hopeful some of those things come soon. But
well, you mentioned earlier skin tones when it comes to skin cancers too, because we all have different skin tones. Are there specific signs that people with darker skin tones need to pay attention to, outside of people that have the lighter skin tones? Is there things that they need to watch for more?
Not so much in terms of what to look out for.
Okay.
You're still looking, in the case of melanomas, you're most of the time looking for dark lesions,
right,
and things that are changing. And we talk about the ABCs. It's actually A, B, C, D, E. So asymmetry, border, color, diameter, and evolution. So a mole should be, if you look at a dark spot, it should be symmetric. If you draw a line down the middle of it, it should be symmetric on both sides. The border should be smooth, not jagged or hazy. Should all be one color, ideally. Multiple colors can be more concerning. The diameter should be about 6 millimeters or less. That's about the diameter of a pencil eraser.
Oh, okay.
So, but kids are born with moles bigger than that all the time.
Yeah.
So by itself, that feature doesn't always mean a lot. And then probably most importantly is E, or evolution. If something's changing over time, it should get looked at. And none of those features mean it's bad. It just, taken in whole, it be a reason to come in and have it looked at.
Now, when you say changing, do you mean just getting bigger in general, or
in any of those ways, in asymmetry, border, color, diameter, diameter? If any of those things are changing over time, or if it starts to itch, burn, bleed, you shouldn't know a mole's there other than looking at it. Now, that could be something as simple as a mole getting caught on your collar, but moles should not be painful, and if they are over time, it's something we should look at. A lot of times they turn out to be nothing concerning, but it's still a marker of potential risk.
Okay.
You asked about skin types. And I think one misconception is having a darker skin type makes you immune from certain types of skin cancers, and that's not true. It does decrease risk, and we know in folks with darker complexions, certain types of skin cancers, particularly the non-melanoma skin cancers, the basal cell and squamous cell carcinomas, their risk is decreased. However, melanoma risk, we don't see that. That's kind of consistent throughout all skin types. So I think one of the misconceptions is if I have a darker complexion, I don't have to protect my skin from the sun, and I don't have nearly as high a risk for some of these skin cancers. And so while that is true for some things to a degree, it's not universally true.
Well, any skin tone can burn, can't it?
Correct.
From the sun?
Yep.
I mean,
yes. Yeah, just basically the amount of UV exposure will dictate that. So with more melanin, which is the pigment in our skin, it can protect from UV damage. And so generally speaking, as you increase the amount of melanin in your skin, you can tolerate more UV exposure before you burn, but you can still absolutely burn.
Okay.
Yes.
So we know, I mean, we've talked about, screenings, obviously, at-home screening, self-exam. When you go in the sun, put on sunscreen. Just cover yourself in it. Or big hats. I don't know, whatever you feel more comfortable in, I suppose. But is there an ideal time of the year for like a full body skin cancer check, or can it be any time?
It can be any time. In training, and for a while, the American Academy of Dermatology was publishing literature that said, check your birthday suit on your birthday. So do your full body skin exams around the time of your birthday.
Yeah.
Whether it's a self exam or with a dermatologist, look things over kind of head to toe at least once a year. It doesn't really matter so much what time of year that is. And I also have people document spots and things on their phone, so we'll keep track of those. I keep records in their medical chart so that we can compare spots from one year to the next. But generally, at least once a year. And if they're at higher risk, sometimes more frequently than that.
So is there anything, as we kind of wrap this one up today, Doctor, is there any one thing that you really, really want people to know about either what you do or what they need to watch out for, aside from obvious things? Is there anything that you really, really want to drill into somebody's head about skin and skin cancer?
Yeah, sure. That no one's truly immune from skin cancer, and that sunlight is the leading cause of most skin cancers, and at least preventable causes. And so do what you can to protect your skin on a regular basis from that damage, whether it be sunscreen use or sun protective clothing. When we look at hats, we all like baseball caps, but they don't do a very good job of protecting our ears, back of the neck, or lower face. So broad-brimmed hats, long sleeves, fabrics that are UV protective, or with sunscreens, putting them on a half hour before you head outside and then reapplying every 2 to 3 hours. Reapplication is the biggest mistake I see in my practice, where folks put sunscreen on before they go out, but they're spending the entire day outside, for example, at a sporting event, and then never reapply it. And so the burn comes in the afternoon.
Is there a lot of people have concerns about certain types of sunscreen? I don't know how well-founded some of that stuff is. Are there some sunscreens that are better than others?
As far as better, it depends. It depends on individuals. Some people are sensitive to some of the sunscreen agents. Generally, when you look at sunscreens, there are two broad classes. There are sunscreens and sunblocks. Sunblocks are the physical sunscreens. Those are usually metal compounds like titanium and zinc. Traditionally, they're very chalky white when you put them on. A lot of people don't like them. The zinc oxide, the classic diaper paste on the nose if you're the lifeguard. Over the years, what they've called micronized those molecules, so now they're smaller. And so when you put them on, they're still a little chalky white, but they actually do rub in and are essentially clear after a few minutes. They are harder to apply and rub in without leaving a residue, but they are generally probably the safest. They also block the broadest spectrum of ultraviolet A and B of all the sunscreens, with the exception of one chemical sunscreen agent. The chemical sunscreens are much more popular. They're the ones that you see in the sprays and the liquids and the easy to apply products. There has been a lot of concern about those products and their safety over the years from different entities, and some of them have their own agendas. Some have been banned, for example, in Hawaii because of concern over damage to coral reefs, and aren't available in all areas. However, they are considered generally safe. Now, the other thing that has come up probably in the last 2 or 3 years has been a concern about benzene in sunscreen products. There was an independent testing facility that found some benzene, and that is another carcinogen in some of the sunscreen products. And it was found largely in the sprays. So when you look at all the products in which it was found, it was found in multiple different companies' products. So there wasn't one company that was a problem, but they were, for the most part, in the sprays. So if that is a concern, and that's still being investigated, and I can't really say with certainty whether that's a real concern or not at this point. There is work being done to look into that. If you're concerned about that, what I generally recommend is steer clear of the sprays, which everybody
that was going to be my last question
because they
for
say,
you.
well, that's the easiest one to apply, and it is. It's the one we all like for our kids, and so I guess the jury's still out on that. But if you're concerned, tend to stick with the lotions and creams. SPF of at least 30. The higher the better, but at least a 30. Any of the brands should be sufficient if applied correctly.
Excellent. Okay. Well, good. Well, thank you very much, Doctor. This again has been just another great conversation that I just think we all know the dangers, right? I think anymore it comes down to the myths that we hear about our skin and our skin damage and skin cancer, like face tans and things like this, right? We all know we got to protect ourselves, but I like for doctors like you to come in and just kind of lay bare what is true and what isn't, so to speak, about getting out in the sun this summer. So thank you very much again, Doctor, for coming in, and I know we're going to talk to you again. I really appreciate it. Dr. Christopher Gasbarre, dermatologist from Monument Health and Spearfish. Thank you, man.
My pleasure. Thank you.